All right, if you're gearing up for your vascular FRCS Viva, you know that landmark trials are absolutely fair game. Today, we're going to do a deep dive into one of the big ones, EVTRA. We're going to break it down into a powerful, structured format that you can use to just nail the question and really impress your examiners. So, here's how we'll tackle it. We've got 6 key stages. We'll kick off with the clinical question that started it all, then break down the design and methods, look at what was actually done and measured, and of course, get into the key results. But we're not stopping there. We'll then critically appraise its limitations and finish up with the most important bit, its impact on your practice, and that safe, structured answer that's going to score you major points in the exam. So let's start at the very beginning. In any Viva, the first thing you've got to show is that you understand why a trial was even necessary. What was the real-world problem that EVA trial was trying to solve?
And this, right here, was the core question. We've known for ages that compression therapy works. It's the cornerstone of treatment. But the big uncertainty, the real question mark, was whether jumping in early and treating those faulty superficial veins with modern endovenous techniques could actually make the ulcers heal faster.
You see, to really get EVRA, you first have to understand the trial that came before it, ESCAR. Now, we knew venous disease was the main culprit for leg ulcers, and compression was standard care. The ESCAR trial tested adding old-school open surgery to that compression. And what it found was interesting. It helped stop ulcers from coming back, it reduced recurrence, but it did absolutely nothing to speed up the initial healing time. And that left this massive gap in our knowledge. Could the newer, less invasive endovenous techniques, if we applied them early, finally crack that healing time problem? That is precisely the question EVRA set out to answer. Right, let's get into the methodology. Examiners absolutely expect you to know these details cold. So this is where you really show you've done your homework on the paper. The easiest way to summarize a trial's design is with the PICO framework. For the population, we're talking about 450 patients with active venous ulcers. The intervention was compression plus early endovenous ablation done within 2 weeks. And that was compared to the comparator group who just got compression alone with their ablation deferred. The primary outcome they measured was simple and to the point: time to ulcer healing. Honestly, this framework is a fantastic way to structure your answer. So what were the specifics? Well, it was a robust, multicentre RCT, which is the gold standard, right? It was conducted across 20 hospitals in the UK, which really helps with its generalizability to our practice. They included patients with a decent arterial supply, an ABI of 0.8 or more, and they were careful to exclude people with really chronic ulcers, those lasting over 6 months, or anyone with significant deep vein blockages. These details are absolutely vital for a complete appraisal. Okay, so we've covered the why and the how. Now for the what. What was actually done to these patients? And what exactly were the investigators measuring? The critical difference here was all about timing. It's so important to get this. Both groups got high-quality compression therapy. That was a given. But in the early intervention arm, those 224 patients had their refluxing veins zapped within just 2 weeks. In the deferred arm, the 226 patients had to wait. Their ablation was only considered after the ulcer healed, or at 6 months if it was still hanging around. That simple difference in timing, that was the heart of the entire experiment. And what were they looking for? Well, the primary endpoint was crystal clear: time to healing. But the secondary endpoints, they add some real depth to the findings. They looked at the healing rate by 24 weeks, they looked at recurrence at 1 year, and they also measured something that's really important from a patient's perspective: the amount of time during that first year that the patient was completely free of ulcers. And now, for the section everyone's been waiting for, the results. These are the numbers that you absolutely, positively have to have at your fingertips for the exam. The top-line message, and this is straight from the author's conclusion in the New England Journal of Medicine, is completely unambiguous. Early ablation worked. It led to faster healing and more ulcer-free time, period. That's the headline. So let's get into those numbers. The headline statistic was the hazard ratio for healing, which came in at 1.38. Now, in simple terms, what does that mean? It means at any point in time, a patient in the early treatment group was 38% more likely to be healed. That's a huge effect. So how did that actually translate into healing time for patients? Well, for the early intervention group, the median time to healing was just 56 days. Now, contrast that with the deferred group, where it took 82 days. That is a 26-day difference. Let that sink in. Patients were getting better nearly 4 weeks faster. In clinical practice, that is a massive, massive difference. And this advantage, it held true when you looked at the healing rate at 24 weeks. A full 85.6% of ulcers in the early group were healed, compared to just 76.3% in the deferred group. The evidence for jumping in early was just consistent across multiple metrics. But no trial is perfect. And this, right here, this is the part of your Viva answer that separates a good candidate from a great one. Your ability to critically appraise the paper and show a balanced view. So what are the potential weak spots here? First, it was a pragmatic trial. This meant centers could use different ablation techniques, laser, radiofrequency, foam. You could argue this introduces some variability. Second, there's a question about generalizability. I mean, they screened over 6,500 patients just to enroll 450, often because many ulcers were older than that 6-month cutoff. So these results might not apply to our patients with really chronic ulcers. And finally, here's a subtle but really important point. The follow-up was asymmetric. A duplex scan at 6 weeks was only required for the early intervention group. You could argue this might have led to more touch-up procedures and biased the technical success in their favor. Okay, let's bring it all home. What did this trial actually change in the real world? And how do you package all of this information into that perfect exam answer? The impact of this trial, it really can't be overstated. EVRA fundamentally changed our practice. It completely flipped the old mantra of heal the ulcer with compression, then maybe we'll think about the veins. The new evidence-based paradigm is now treat the veins promptly in order to heal the ulcer. It's a total shift in thinking. So here it is, your structured answer, all in one place. 1. Start with the background, positioning EVRA as the direct answer to the healing time question that ESCAR left unanswered. 2. Describe the design, a UK multicentre RCT comparing early versus deferred ablation. 3. State the primary endpoint, time to healing. 4. Give the key result. Early ablation led to faster healing with that hazard ratio of 1.38. 5. Quote the numbers. The median healing time was slashed from 82 down to 56 days. And 6. The conclusion. EVRA established that early intervention is the new standard of care. You deliver that, and you've covered all the bases perfectly. And just to bring it all home, if the examiner leans forward and asks you to summarize the trial's importance, here is the polished consultant-level answer you need to have ready. EVRA was a landmark multicentre RCT which demonstrated that for patients with venous ulcers, early endovenous ablation of superficial reflux combined with compression therapy results in significantly faster ulcer healing and more ulcer-free days at 1 year compared to compression alone with deferred treatment. The key finding was a reduction in median healing time from 82 to 56 days, establishing a new standard of care to treat the underlying venous disease promptly. You deliver that with confidence, and you have absolutely nailed the question.